Dr. Grady, why was it that there was no bells or whistles that went off when some... Now, I've been up to Redding, and I know it's not anywhere near populated like Southern California. Why would a hospital that did 600 heart procedures, why wasn't anything going on? I mean, if you've got 12,000 people in your community and 600 are doing this surgery, there's something wrong with your community.
Well, that's correct. And the statistics about Reading Medical Center, including their peer review statistics, were kept a secret from the medical staff by the hospital administration. They were able to, and the way that worked is that Dr. Moon, the cardiologist, was able to set up an independent organization called the Northern California Heart and Vascular Institute within Tenet Corporate, which covered several hospitals, not just RMC, but also Doctors Hospital in Modesto. I believe there was a hospital in LA that was part of that as well. And so they set up their own independent organization, and they did their own peer review. So, for example, my committee received reports about peer review activities that were going on in other aspects of hospital care. However, we never received any peer review reports from the Heart Service. Now, in, I believe it was 1999, the hospital was cited by California LNC for not conducting peer review on several patients that were identified as having complications within the heart program. And as part of the conditions that they imposed on the hospital, they had to have a correction plan that, that required peer review to be done. The quality committee was part of that plan. We were supposed to review these reports, but again, despite my asking several times, the hospital administration simply refused to give up those reports. And in fact, peer review wasn't being done, and it wasn't really the full extent of the whole problem wasn't really known until the FBI raid and the indictment. But essentially, what you had there is you had a physician who was very influential within Tenet Corporate, who was able to carve out his own independent organization that was not subject to medical oversight through the medical staff.
I think even beyond the hospitals, I'm just wondering, all of those procedures, I know that all of those patients weren't wealthy that paid for it out of their pocket. So how is it that the plans, the state of California that covers Medicare, the federal government that covers Medicaid, how did they not link something there?
Well, I don't know the answer to that question. I can tell you that individual physicians with the community were aware of not only individual cases, but the overwhelming number of cases that were being performed. I believe there were 7 complaints filed with the medical board prior to the FBI indictment, but no effective action was taken. The reasons for that, I don't know. So, I mean, there were lots of people that were there was a problem. The physicians who were running this organization tended to be somewhat intimidating towards other people in the medical staff that raised questions. And to be honest, you know, after this had gone on for several years, I think people sort of had despaired of their ability to interest the government in solving this problem.
Well, I think part of the fault lies then within our own system that didn't say, you know, you've got like a whole cluster of something wrong in this area. Dr. Anasted, you had a question?
Actually, that was the question. It was a very good answer. I guess my question was going to be, since I infer from your testimony that you support Lumetra's outside independent review for every complaint, every peer review complaint, my question was going to be, how would that have changed what happened in Reading? But I think you answered it by saying there'd no longer be an independent hospital-based entity, and it would have to go to what? But then who makes the judgment that it has to go to peer review in the first place?
Well, that's a good question. The root cause of the problem at RMC, the mechanism under which this all took place, was that the cardiologist involved was using a new technology, an intravascular ultrasound, which he claimed would show coronary artery problems that were invisible on angiogram, okay? And it actually turns out in the fullness of the time, we know that that is not true, and that technology is no longer used. He was also using it, we think, inappropriately, and was not saving his images. But I think in a reasonable peer review effort at the heart program would have noted that he wasn't saving his images, and that would have raised a red flag. I favor regional peer review simply because it eliminates the motivation for inadequate peer review, and it also eliminates the motivation for malicious peer review of the type that Dr. Milikowski is talking about. Because if I'm reviewing a chart on a case that happened in LA, for example, okay, I have no personal stake in the outcome of that peer review. I can give a completely unbiased and a completely impartial, judgment about that case. And I think that until we have an impartial system, until we get peer review out of the hospital, I think we're going to be still having the types of problems we're having now, not just the sham peer review, which I think is a smaller problem, but the inadequate peer review, which I think is a threat to public safety.
So how do you react to Dr. Lowe's assertion that the vast majority are minor and can be handled in your hospital system? You've been part of peer review in your hospital for probably a couple of decades. Would you say every one of those cases had to go to a outside independent third party?
No, but I think that there are certain cases that do. There are certain
Okay, and I guess my point is, where's the trigger? Because regardless of what we say, the cost can be no object. The fact of the matter is that when you get a group of physicians who are not paid to handle, the majority of these very small complaints, and then when one comes up to a threshold that it really needs to go to the next level, and hopefully it's not necessarily the state board at that time, but an outside peer review or an independent. I guess I want to know what is that trigger? At what point would you say, hey, this peer review complaint needs to go to the next level and needs to leave the doors of this hospital?
Let me answer that question indirectly, because I don't really know where the trigger should be. But what I would recommend is that we develop a group of people who are essentially peer review professionals, people who do research in peer review, people who study the psychiatric factors involved in peer review. There's a lot of nuances involved in peer review that that the average physician in the hospital doesn't know about. There are physicians, for example, with psychiatric illnesses that don't present the way that psychiatric illnesses normally do in the general population. There are physicians who are impaired. Okay, there are physicians who can't keep up with the pace of learning new procedures as time goes on, and so it's not a matter of just sitting down with Dr. Smith and talking to him about his cases. I mean, you have to be able to recognize those sort of events. You need to be trained. You need, I think, to be a professional. Having a regional system, I think, solves that problem. And what I would suggest is to work with people who do research on this and let them advise the government about where the triggers would fall. I think there are certainly some events that clearly would, if you have somebody, for example, who has a large number of intraoperative complications or problems, that's something that should go. But there are other things as well. And I'm not the best person to answer that question, but I think you really need to set up a system of professionals so that, and then let them through, research and through their experience help define where those levels should be.